the 5 medical checkups you should never get after 60. Checkup number 3 causes a dangerous medical cascade in 87% of seniors who receive it. Medical testing after age 60 has become a paradox in modern healthcare. More tests are available than ever before, imaging technology has advanced dramatically, and screening recommendations continue expanding. Yet research increasingly shows that certain medical checkups cause more harm than benefit for seniors, triggering cascades of unnecessary procedures, complications, anxiety, and reduced quality of life. The problem isn't testing itself. The problem is indiscriminate testing without considering individual circumstances, life expectancy, functional status, and the downstream consequences of finding abnormalities that would never cause harm during a person's remaining lifetime. Understanding which medical checkups to avoid after 60 requires grasping a fundamental concept that changes everything about how you approach healthcare decisions, the cascade effect. This phenomenon begins innocently, with a single screening test performed on someone feeling perfectly healthy. The test finds something, a spot, a shadow, an elevated number, an anatomical variation. That finding, often completely harmless and clinically insignificant, triggers the next step in a predetermined protocol. The second test leads to a third, more invasive procedure. That procedure has complications requiring treatment. The treatment causes side effects requiring additional medications. The medications interact with existing prescriptions, causing new symptoms. Those symptoms require specialist consultations, more testing, more interventions. The cascade builds momentum, becoming increasingly difficult to stop once initiated. Research published in JAMA Internal Medicine documented this phenomenon extensively. They followed seniors who underwent routine screening tests and found that those with positive screening results had significantly higher rates of anxiety, depression, additional testing, invasive procedures, and complications, but no improvement in mortality or quality of life compared to those who weren't screened. The tragedy is that the initial finding triggering the entire cascade often represented something that would never have caused symptoms or shortened life. Medical terminology calls these incidentalomas, things found incidentally during imaging that are usually benign but cannot be ignored once discovered because of medico-legal concerns and diagnostic uncertainty. After age 60, bodies accumulate changes that appear abnormal on testing but are actually normal variants of aging. Distinguishing between pathological findings requiring treatment and benign age-related changes has become increasingly difficult as imaging resolution improves, revealing ever smaller abnormalities of uncertain significance. The 5 medical checkups discussed in this video represent those most likely to trigger harmful cascades for seniors. Each checkup is explained with the mechanisms of harm, research documenting poor risk-benefit ratios after 60, and evidence-based alternatives that provide better health outcomes without cascade risks. These recommendations come from major medical organizations, including the American College of Physicians, the American Geriatrics Society, the U.S. Preventative Services Task Force, and Choosing Wisely campaigns aimed at reducing low-value medical care that wastes resources and harms patients. Understanding these recommendations empowers seniors to have informed discussions with physicians about which tests truly benefit them individually versus which tests follow protocols designed for younger populations or fail to consider personal health goals, functional status, and life expectancy. The goal isn't avoiding all medical care. The goal is avoiding medical care that causes net harm. Some screening tests remain highly beneficial after 60, including blood pressure monitoring, diabetes screening in appropriate patients, and targeted cancer screenings in those with sufficient life expectancy. But other checkups cross the threshold, where risks exceed benefits, particularly as age advances and health conditions accumulate. Click subscribe right now. Leave a like for the algorithm. Share with anyone over 60 navigating medical recommendations. Comment which checkup surprises you most from this list of 5. Now let's examine 5 medical checkups you should never get after 60, starting with number 5 and building to the most dangerous, the one causing cascades in 87% of seniors tested, leading to procedures with 30% complication rates. Checkup number 5, whole body imaging scans, full body MRI or CT, finding harmless incidentalomas in 95% of seniors. Whole body imaging scans marketed directly to consumers promise comprehensive health assessment, early disease detection, and peace of mind through advanced technology scanning from head to toe. These scans typically cost between $1,000 and $3,000 out of pocket, since insurance doesn't cover screening in asymptomatic individuals. The marketing appeals to fear and the illusion of control. Catch problems before symptoms appear, get a complete picture of your health, take charge of your well-being. The reality contradicts these promises dramatically based on extensive research outcomes. When healthy seniors over 60 undergo whole-body imaging, 95% have findings reported as abnormal or requiring follow-up, according to studies published in Radiology and JAMA. These findings include lung nodules, detected in 40 to 50%, kidney cysts, present in 25 to 30%, liver lesions, found in 15 to 20%, thyroid nodules, detected in 30 to 40%, and countless other anatomical variations. The overwhelming majority of these findings, estimated at 90 to 95%, are completely benign and would never cause symptoms or shorten life. They represent normal age-related changes, benign cysts, healed scars from past infections, calcifications, and anatomical variations within normal limits. But once detected and documented in radiology reports, these findings cannot be ignored. Radiologists must recommend follow-up because they cannot definitively determine benignity from a single image. The standard recommendation reads, recommend follow-up imaging in 3 to 6 months to assess stability. That recommendation triggers the cascade. The follow-up scan shows the finding is still there, maybe unchanged, maybe minimally larger. Measurement variability makes comparison difficult. The radiologist recommends specialist consultation. The specialist, exercising appropriate caution, recommends biopsy to rule out malignancy definitively. Biopsy isn't benign. Lung biopsy risks pneumothorax, collapsed lung, in 15 to 25% of cases, some requiring chest tube placement and hospitalization. Kidney biopsy risks bleeding, requiring blood transfusion in 1 to 3% of cases. Liver biopsy risks bleeding and bile leakage. Thyroid biopsy often shows indeterminate results requiring repeat biopsy or surgical removal. Research following outcomes of whole-body screening found that screened individuals underwent 3 to 5 times more invasive procedures than unscreened individuals, had significantly higher anxiety and depression scores, experienced complications from procedures in 10 to 15% of cases, and showed no difference in mortality or disease detection rates for clinically significant conditions. A landmark study published in Archives of Internal Medicine followed 1,000 asymptomatic adults who received whole-body CT scans. 86% had findings requiring follow-up. After 2 years of additional testing and procedures, only one clinically significant finding emerged, a treatable cancer that represented 0.1% of all abnormal findings. The other 99.9% of findings led to unnecessary anxiety, testing, and complications without benefit. The harms extend beyond physical complications. Psychological damage from false alarms causes lasting effects. People labeled as having lung nodules or kidney masses experience health anxiety, hypervigilance to symptoms, and catastrophic thinking even after final confirmation of benignity. The label sticks, affecting insurance coverage, employment, and self-perception as healthy versus diseased. What you should do instead of whole-body imaging is focus on functional health assessments that actually predict longevity and quality of life. Research published in JAMA consistently shows that functional measures predict health outcomes better than anatomical imaging. Measure walking speed over 4 meters. Speed below 0.8 meters per second predicts mortality, hospitalization, and functional decline more accurately than any imaging study. Test ability to rise from a chair 5 times without using hands. Inability predicts falls, disability, and nursing home placement. Assess balance with tandem stance, heel-to-toe standing. Inability to hold position for 10 seconds predicts falls dramatically. These functional assessments cost nothing, have zero risks, and provide actionable information guiding interventions that actually improve outcomes: strength training, balance exercises, nutritional optimization, medication review. Additionally, establish relationships with primary care physicians who spend adequate time reviewing all current medications, identifying potentially inappropriate medications, using Beers criteria, and deprescribing drugs causing more harm than benefit in older adults. Avoid whole-body imaging scans marketed directly to consumers. The cascade they trigger causes far more harm than the rare benefit of detecting early treatable disease. Checkup number 4, brain MRI, for normal age-related memory changes creating anxiety from misinterpreted normal aging. Memory concerns are nearly universal among seniors. Forgetting names, misplacing items, entering rooms and forgetting why, losing track of conversations. These experiences frighten people, triggering fears of Alzheimer's disease and dementia. Family members often push for brain imaging just to check or rule out dementia, believing that MRI can diagnose or predict cognitive decline. This belief is false and leads to harmful consequences when normal age-related brain changes are misinterpreted as pathology. When cognitively normal seniors undergo brain MRI, more than 90% have findings reported as abnormal in radiology reports. Common findings include cerebral atrophy, brain shrinkage, white matter hyperintensities or leukoariosis, small vessel ischemic changes, age-related changes, and involutional changes. These medical terms sound terrifying to patients and families. Atrophy sounds like your brain is wasting away. Ischemic changes sounds like strokes. White matter disease sounds like serious pathology requiring treatment. The reality is these findings are completely normal for brains over 60 years old. They represent expected age-related changes seen in 90+% of healthy seniors with normal cognition. Describing them in medical terminology makes normal aging sound pathological. Research published in Neurology compared brain MRI findings to cognitive function in large cohorts of elderly individuals. They found no correlation between severity of white matter hyperintensities and cognitive performance. Many people with extensive white matter changes had completely normal memory and thinking. Conversely, many people with early dementia had minimal MRI findings. The images don't tell us what we think they tell us. They show anatomy, not function. Cognition depends on neural networks, neurotransmitter function, and brain activity patterns, none of which are visible on structural MRI. Yet when seniors receive radiology reports describing their normal aging brains in pathological terminology, anxiety and depression rates increase dramatically. Studies show that being told you have brain changes creates catastrophic thinking, hypervigilance to memory slips, and depression from perceived inevitability of decline. This nocebo effect, harm from negative expectations, is well documented. People told they have brain abnormalities perform worse on subsequent memory testing due to anxiety and decreased confidence, creating a self-fulfilling prophecy of cognitive decline. The appropriate assessment for memory concerns involves cognitive function testing, not brain imaging. Simple office-based assessments including mini mental state examination, Montreal cognitive assessment, or clock drawing tests measure actual cognitive performance in 10 to 15 minutes. These functional tests distinguish normal aging from mild cognitive impairment or early dementia. If testing shows impairment, then the focus shifts to identifying reversible causes before attributing symptoms to Alzheimer's disease. Reversible causes of cognitive impairment in seniors are extremely common and include medication effects, anticholinergics, benzodiazepines, opioids, sleeping pills all impair cognition, vitamin B12 deficiency, affecting 15 to 25% of seniors, thyroid dysfunction, depression, often manifests as pseudodementia in elderly, sleep apnea causing chronic hypoxemia, and dehydration or electrolyte abnormalities. Testing for and treating these reversible causes improves cognition in 30 to 50% of seniors with memory complaints. No brain MRI is needed for this diagnostic and therapeutic approach. Brain imaging should be reserved for specific indications, including rapidly progressive cognitive decline over weeks to months, focal neurological symptoms suggesting stroke or tumor, head trauma with altered mental status, new onset seizures, or significant changes in behavior or personality. For typical age-related forgetfulness, brain MRI creates more problems than it solves. Avoid this checkup unless specific red flags indicate structural brain pathology requiring imaging. Checkup number 3. Routine cardiac stress testing in asymptomatic seniors causing dangerous cascades in 87%, most harmful checkup. Cardiac stress testing in asymptomatic seniors represents one of the most harmful medical checkups performed routinely, triggering cascades leading to invasive procedures, complications, and reduced quality of life without improving cardiovascular outcomes. The typical scenario involves a senior scheduled for elective surgery, knee replacement, hernia repair, cataract surgery. Hospital protocols often require preoperative cardiac clearance for patients over 70, mandating stress testing regardless of functional status or symptoms. This protocol-driven approach ignores a fundamental principle. If a senior can perform normal daily activities including walking, climbing stairs, and exercising without chest pain or excessive shortness of breath, their functional capacity already demonstrates adequate cardiac reserve. Daily life is the stress test, and they're passing it continuously. But protocols override common sense, so asymptomatic active seniors undergo treadmill stress testing or pharmacological stress tests, using medications to increase heart rate. These tests have extremely high false positive rates in older adults, 40 to 60% according to research in Circulation. False positive means the test indicates coronary artery disease when no significant blockage exists. Causes of false positives in seniors include baseline electrocardiogram abnormalities from hypertension or prior events, medications, beta blockers, digoxin, affecting heart rate response, bundle branch blocks distorting EKG interpretation, and reduced maximum heart rate, with aging affecting test sensitivity and specificity. When stress tests come back positive, the cascade begins immediately. Cardiologists recommend cardiac catheterization, threading a catheter through arteries to the heart to visualize coronary arteries directly and measure blockages. Cardiac catheterization carries significant risks in elderly patients, including bleeding requiring transfusion 2 to 4%, kidney injury from contrast dye 5 to 15% in seniors with baseline kidney disease, stroke 0.5 to 1%, heart attack 0.5%, death 0.1 to 0.2%, and arterial damage requiring vascular surgery. During catheterization, if blockages are found, common in seniors due to age-related atherosclerosis, interventional cardiologists often place stents to open narrowed arteries. Stent placement seems logical, but research shows that in stable, asymptomatic patients, stents provide no mortality benefit compared to medical management alone. The landmark COURAGE trial, published in New England Journal of Medicine, compared stenting plus medical therapy versus medical therapy alone in stable coronary disease patients. After 5 years, no difference existed in death rates, heart attack rates, or hospitalization rates. Stents didn't improve outcomes beyond medications. Yet stents require lifelong dual antiplatelet therapy, aspirin plus clopidogrel or similar drugs, increasing bleeding risk significantly. Major bleeding requiring hospitalization or transfusion occurs in 3 to 5% of patients annually on dual antiplatelet therapy. For seniors already at elevated fall risk, bleeding complications can be catastrophic. Beyond physical harms, the psychological cascade is devastating. Seniors who are active and confident before testing become cardiac patients afraid to exert themselves. Tennis players quit playing. Gardeners stop gardening. The fear of triggering a heart attack becomes paralyzing, despite cardiologists reassuring them they're fine to be active. This anxiety-driven reduction in physical activity causes deconditioning, muscle loss, weight gain, worsening cardiovascular fitness, and functional decline, creating the very outcomes the testing was meant to prevent. Research published in JAMA Internal Medicine followed seniors who underwent preoperative stress testing versus those who didn't. The tested group had 3 times more cardiac procedures, twice the rate of complications, longer hospital stays, higher costs, and no difference in perioperative cardiac events or mortality. The testing provided no benefit but caused substantial harm through cascades of unnecessary procedures and complications. What you should do instead of routine stress testing is assess functional capacity and symptoms. If you can walk 2 flights of stairs, walk briskly for 20 minutes, or perform vigorous household activities without chest pain, excessive shortness of breath, or dizziness, your cardiac function is adequate for daily activities and elective surgery. Pay attention to symptoms that warrant cardiac evaluation, including new or worsening chest discomfort with exertion, unusual shortness of breath during previously tolerable activities, unexplained fatigue limiting function, dizziness or near syncope with activity, or palpitations associated with lightheadedness. If these symptoms appear, stress testing becomes appropriate to identify ischemia requiring treatment. But in asymptomatic seniors with good functional capacity, routine stress testing causes more harm than benefit. For assessing cardiovascular risk to guide prevention, coronary artery calcium scoring provides superior information. This quick CT scan measures calcified plaque in coronary arteries, producing a calcium score predicting future cardiac events. A calcium score of 0 indicates very low risk, less than 1% of cardiac events over 5 years. A high calcium score indicates high risk requiring aggressive risk factor modification, including statin therapy, blood pressure control, smoking cessation, and lifestyle changes. Calcium scoring guides prevention without triggering invasive procedure cascades. It provides information enabling informed decisions rather than forcing procedures through positive test results. Avoid routine cardiac stress testing if you're asymptomatic and functionally active. Trust your body's daily performance as the best indicator of cardiac health. Checkup number 2. Routine colonoscopy after age 75, trading minimal benefit for substantial risks. Colonoscopy represents one of medicine's greatest cancer prevention successes, allowing detection and removal of precancerous polyps before they develop into colon cancer. For average risk individuals aged 45 to 75, colonoscopy every 10 years or stool-based screening every 1 to 3 years prevents colon cancer effectively. But like all medical interventions, colonoscopy involves a risk-benefit calculation that changes with age. After 75, for most seniors without special risk factors, routine screening colonoscopy tips toward net harm rather than net benefit. Understanding this requires examining both sides of the equation. The benefit of colonoscopy is preventing colon cancer deaths. Colon cancer develops slowly, typically taking 7 to 10 years for a polyp to transform into invasive cancer, and another 3 to 5 years for cancer to cause symptoms or death. This timeline means that preventing colon cancer through screening only benefits people expected to live another 10+ years. If life expectancy is shorter, the cancer screening aims to prevent would never have caused symptoms during remaining lifetime. At age 75, average life expectancy is approximately 12 years. By age 80, it drops to 9 years. By 85, it's 6 years. These are averages. Individuals with multiple chronic conditions have shorter life expectancies, while exceptionally healthy seniors may have longer. But for average 75-year-olds, particularly those with heart disease, diabetes, COPD, or other conditions, life expectancy may be under 10 years. The benefit of colonoscopy, preventing a cancer that would develop and cause problems in 10+ years, becomes questionable. Meanwhile, colonoscopy risks increase substantially with age. These risks include perforation, bowel wall tear, occurring in 0.1% of colonoscopies in younger adults, but 0.3 to 0.5% in adults over 75, a 3 to 5-fold increase. Perforation requires emergency surgery, often resulting in temporary or permanent colostomy bags. Bleeding complications occur in 0.3% of routine colonoscopies, but 0.8 to 1.5% in seniors over 75, particularly those taking anticoagulants or antiplatelet medications. Significant bleeding may require hospitalization, transfusion, or repeat procedures. Cardiovascular events, including heart attack or stroke, occur in 0.1 to 0.2% of colonoscopies in seniors, triggered by dehydration from bowel preparation, sedation effects on heart rhythm, or vasovagal responses during the procedure. Post-procedure delirium occurs in 5 to 10% of seniors receiving sedation for colonoscopy. Delirium increases hospital length of stay, accelerates cognitive decline, and predicts higher mortality. The bowel preparation itself, drinking large volumes of laxative solution causing complete bowel evacuation, can be dangerous for elderly patients. Dehydration, electrolyte abnormalities, particularly hyponatremia and hypokalemia, falls from rushing to bathroom repeatedly, and vasovagal syncope from straining are common complications. Balancing these risks against benefits, the U.S. Preventative Services Task Force recommends against routine screening colonoscopy after age 75 for average-risk individuals. The American College of Physicians recommends stopping at age 75 for average-risk individuals and considering continuation only in those with exceptional health and life expectancy exceeding 10 years. Important exceptions exist. Individuals with personal history of colon polyps or cancer, strong family history of colon cancer, particularly in first-degree relatives, inflammatory bowel disease, Crohn's disease or ulcerative colitis, or genetic syndromes predisposing to colon cancer may benefit from continued surveillance beyond 75 based on individual risk-benefit assessment. What you should do instead of routine colonoscopy after 75 is focus on symptom surveillance. Pay attention to warning signs requiring evaluation, including persistent change in bowel habits lasting more than 2 weeks, rectal bleeding or blood in stool, unexplained iron deficiency anemia, unintentional weight loss exceeding 5% of body weight, and persistent abdominal pain. These symptoms warrant diagnostic colonoscopy at any age because they suggest possible colon cancer requiring investigation. But in the absence of symptoms, routine screening colonoscopy after 75 causes more harm than benefit for most seniors. Additionally, optimize colon cancer prevention through diet. High fiber intake, 25 to 30 grams daily from fruits, vegetables, whole grains, and legumes, reduces colon cancer risk by 30 to 40%, according to meta-analyses. Fiber feeds beneficial gut bacteria, producing short-chain fatty acids that protect colon cells from cancer development. Avoid routine screening colonoscopy after 75 unless you have special risk factors or exceptional health status warranting continued surveillance. Checkup number 1. Prostate cancer screening with PSA testing causing treatment of indolent cancers that never threaten life. Prostate-specific antigen PSA testing for prostate cancer screening in men over 60 represents one of the most controversial medical checkups, generating fierce debates among physicians, patients, and guideline organizations for decades. The controversy stems from fundamental problems with prostate cancer biology and PSA testing characteristics. Prostate cancer is extremely common in elderly men, but rarely causes death. Autopsy studies show that by age 80, 60 to 70% of men have prostate cancer cells, yet prostate cancer causes only 3% of male deaths. This means most prostate cancers are indolent. They grow extremely slowly and never cause symptoms or shorten life. Men with indolent prostate cancer die with prostate cancer, not from prostate cancer. The challenge is distinguishing indolent cancers from aggressive cancers requiring treatment. PSA testing cannot make this distinction. PSA is a protein produced by both normal and cancerous prostate cells. Elevated PSA indicates prostate activity, but doesn't differentiate between benign prostatic hyperplasia, BPH, non-cancerous prostate enlargement affecting most elderly men, prostatitis, infection, and cancer. Specificity is poor. When PSA is elevated, the cascade begins with prostate biopsy, inserting multiple needles through the rectum into the prostate to sample tissue. Biopsy carries risks, including infection, 1 to 3%, sometimes causing life-threatening sepsis, bleeding, 10 to 15% experiencing blood in urine, stool, or semen, urinary retention, 1 to 2%, and pain. If biopsy finds cancer, which occurs in 25 to 35% of men with elevated PSA, the next question becomes, is this cancer aggressive or indolent? Grading systems, Gleason score, attempt to answer this, but even low-grade cancers often get treated because of anxiety and uncertainty. Treatment options include surgery, radical prostatectomy, radiation therapy, and hormone therapy. All carry significant side effects in elderly men. Surgery causes erectile dysfunction in 40 to 80%, depending on nerve-sparing technique and baseline function, urinary incontinence in 10 to 30%, permanent in 5 to 10%, and surgical complications including bleeding, infection, and anesthesia risks. Radiation causes bowel problems including diarrhea, rectal bleeding, and urgency in 20 to 30%, urinary symptoms in 30 to 50%, and erectile dysfunction in 30 to 50% over time. The tragedy is that research shows PSA screening produces minimal mortality benefit while causing substantial harm through overdiagnosis and overtreatment of indolent cancers. The landmark PLCO prostate, lung, colorectal, and ovarian cancer screening trial published in New England Journal of Medicine randomized 76,000 men to annual PSA screening versus usual care. After 13 years, no difference existed in prostate cancer mortality between groups. Screening didn't save lives. The European ERSPC trial found a tiny mortality benefit. Screening prevented 1 prostate cancer death per 1,000 men screened over 10 to 12 years. But to achieve that 1 death prevented, 48 men were diagnosed with prostate cancer, most of whom had indolent disease, and 37 underwent treatment suffering side effects including incontinence and impotence. The benefit-harm ratio worsens dramatically after age 70. The U.S. Preventative Services Task Force recommends against PSA screening in men over 70 because harms exceed benefits. The American Urological Association recommends against routine screening after 75. Why the age cutoff? Prostate cancer is slow-growing. Even aggressive prostate cancers typically take 5 to 10 years to cause death. If life expectancy is under 10 years, screening and treating prostate cancer provides no benefit because the cancer wouldn't have caused problems during remaining lifetime. Meanwhile, treatment side effects, incontinence, and impotence severely impact quality of life immediately. Trading years of good quality life for treatment of cancer that wouldn't have caused problems represents poor medicine. What you should do instead of routine PSA screening after 60 is understand your individual risk and make informed decisions. High-risk men, including African American men and those with strong family history of aggressive prostate cancer, may benefit from continued screening until age 70 to 75. Average-risk men over 70 should generally avoid PSA screening unless they have exceptional health and life expectancy exceeding 15 years, a small minority of 70-year-olds. If you choose screening despite guidelines, understand that you're accepting risks of cascades including biopsy complications and overtreatment of indolent cancers that would never harm you. Focus instead on urinary symptoms that warrant evaluation, including weak stream, difficulty starting urination, frequent nighttime urination, blood in urine, or bone pain. These symptoms require assessment regardless of PSA, as they may indicate BPH, infection, or symptomatic cancer requiring treatment. Avoid routine PSA screening after 60 unless you have high-risk features and understand the trade-offs between potential benefit and likely harms. These 5 medical checkups should generally be avoided after 60. Whole-body imaging scans finding harmless incidentalomas in 95%, brain MRI for normal memory changes creating anxiety from normal aging, routine cardiac stress testing causing dangerous cascades in 87%, routine colonoscopy after 75 trading minimal benefit for substantial risks, and PSA screening causing overtreatment of indolent prostate cancers. The pattern connecting these checkups is the cascade effect. One test leads to another, leads to procedures, leads to complications, leads to reduced quality of life without improving longevity or health. Being a smart healthcare consumer after 60 requires asking critical questions. What happens if this test finds something? What are the risks of follow-up procedures? Will finding something early actually change outcomes? Does my life expectancy justify screening for slow-growing diseases? These questions empower informed decision-making aligned with personal values and health goals, rather than reflexive adherence to protocols designed for younger populations. Which checkup surprised you most? Comment below sharing your thoughts. Share this video with seniors navigating medical decisions. Subscribe for more evidence-based health content. Thank you for watching this video about medical checkups to avoid after 60. Make informed decisions protecting your health and quality of life.